Welcome everyone, and thank you for joining our August My Macular and Me webinar, which is on genetic counselling and inherited eye disease. For those who don't know me, I'm Ed Holloway and I'm the Chief Executive of the Macular Society, and I'm hosting this evening. And I'm delighted to introduce our guest speaker for tonight, who is Elena Schiff, a genetic counsellor at Moorfields Eye Hospital, where she's been working for over 6.5 years with both adult and paediatric patients who have Mendelian inherited eye diseases. Elena earned her undergraduate degree in genetics before pursuing an MSc and PhD in human molecular genetics. Her research and clinical work extends beyond genetics. She has worked on the molecular diagnosis of conditions including Fragile X syndrome, cystic fibrosis, Hunter syndrome, and genetics of inflammatory bowel disease. Elena has authored over 40 scientific papers, including eight as first author, and has taught medical genetics at both undergraduate and postgraduate levels at London Metropolitan University, where she holds a PG Cert in higher education. Tonight, she'll be talking us through the essential role of genetic counsellors and will help us to understand the complexities surrounding inherited macular disease. She'll explore the likelihood of inheriting these conditions, explain the various genetic tests available to patients and families, and importantly, she'll discuss what test results mean for individuals and their loved ones. If you have any questions as Elena's talking, please do add them to the chat, and then we'll ask them after she's finished presenting. So welcome, Elena, and thank you again for joining us. And now I'm going to hand over to you.
Okay, hello everyone, good evening, and thank you very much for joining and for having me today. It's a pleasure to present today. So as Ed said, my name is Elena Schiff and I work in Moorfields Eye Hospital in the genetics clinics alongside 5 consultants who are genetic ophthalmologists and 3 other genetic counsellors. And there we meet individuals and families with inherited eye conditions. So today I'm going to talk about what a genetic counsellor does and how that role might be relevant to people who are affected by macular disease, specifically the types that run in families. So I'm not going to talk about age-related macular degeneration, which is slightly different, and it's what we call a complex disorder or multifactorial, because there's lots of different genes and lots of different environmental factors that cause age-related macular degeneration. But I'm going to focus on the macular conditions that are inherited and are caused, Ed mentioned before, Mendelian, after Gregor Mendel, who was one of the first people who worked out how genetics works. And that's where genetic counsellors get involved. So what is a genetic counsellor? You might think of us as someone who is a translator or a guide, because we help people understand how their genes, those are the instructions in our cells, tell the body how to make everything. So how our genes work and how they can influence our health. And we guide people through the genetic clinics and through any testing that they might do. And when the results come through, we go through that with them and explain what they mean and where they can go with that. And we support people in those situations. So what do we do in a genetics clinic if somebody is referred to us? What's the first thing that we do when we meet a family? Well, first of all, we want to take time to get to know the family or the person that's there in front of us. And we ask about their medical history. We don't only ask about their medical history, we actually ask about their family history. And we might draw with them what we call a pedigree or a family tree that might go back several generations, if possible. And we ask a lot of questions, and that's not because we're nosy and it's not because we're inquisitive and intrusive, but really the questions that we ask are going to help us work out what condition they might have and how they're inherited, how that condition is inherited. So questions, you know, do you have children? How many children do you have? Girls or boys? Are they from the same partner? Do you have brothers and sisters? Are they from the same parents? How many children do your brothers and sisters have? Are your grandparents alive? all these questions, you know, how old were they when they passed away? Who's affected? Do you have cousins who are affected? Were your parents related to each other, possibly distantly? Lots of questions like this. We ask about the ethnicity, and we're trying to build an idea and get some clues as to what of the many genes that could be causing the macular condition, what gene could be causing it, and how it might be inherited. So when we look at a family and we look at that pedigree, that family tree, we already can recognize certain signs usually as to what's going on. Now, asking all those questions, as you can imagine, can be quite challenging and emotional for the person sitting there, because it can bring up all kinds of things. It can bring up memories of estrangement in a family, or divorce or death, all these things, because we're asking all these details about other family members. So it can be quite difficult going through a family tree. You know, you think, oh, you just tell everyone, but actually families, you know, most families are complex, and there can be emotional issues that people are suppressing that we're bringing up just by asking some questions of, do you have any half siblings, things like that. So of course we need to take that into account and be there for the family, and if we see that we're going too far or it's too difficult, we'd obviously stop. So once we have this family information, we can start talking to the person a bit about genetics, and the different possible inheritance patterns, because what people often really want to know is, they want to know, is there a risk to my children or grandchildren? I've got a genetic condition, or there's a genetic condition in my family. Is there a risk that my children will be affected? So first, if you don't mind, I'll talk a little bit about genes. I won't give too much detail, and this might be things that many of you know, but just a little bit about how our genes work. We all have inside our cells our DNA, and that's the hereditary instructions. It's like the blueprint, and it tells the body how to make everything. And this DNA is arranged in these very long strands that we call chromosomes. And along our chromosomes, we have our genes. And each gene is like a recipe for a specific enzymal protein. And as long as the DNA in that gene is spelled correctly, then everything will work as it should do. But sometimes there are changes in our DNA, and that would mean that somebody has a gene that isn't giving the correct instruction to the body, and something won't work as it should. Now, I mentioned these long strands called chromosomes. We each have 2 sets of chromosomes, 2 sets. We have 23 pairs of chromosomes with all the genes on them, because we get 1 set from mum and 1 set from dad. So for most of our genes, we have 2 copies. When we have children, we actually only pass on 1 of our 2 sets, and it's random which one we pass on, because they'll get the other set from the other parent. So if we have 2 genes, 1 comes from mum, 1 comes from dad, only 1 of those is going to be passed on to each child, and that's going to be very random. So these genes, how they're passed down and how they're inherited, they can be inherited in slightly different ways. There's a few different inheritance patterns, and they depend on where the gene is. And it also depends on, do we need 2 normal copies of that gene for normal function, or is just 1 normal copy of that gene enough for normal function? So there's 3 main types, and they might sound technical, but really they're just different ways that genes can be passed on in families. One type is autosomal recessive, another type autosomal dominant, and then there's X-linked. And I'll go into a bit more detail with inherited macular conditions for these 3 types. So here on this slide, there's 3 different examples where we might see someone in clinic with 3 different inheritance patterns. So the first one, Stargardt disease, that's actually the condition that we see the most of in Moorfields. Stargardt disease is an autosomal recessive condition, and it usually starts in childhood, blurry vision, lower visual acuity, or early adulthood. And some forms of Stargardt's can start in later adulthood. Another condition that we see quite a lot of, another macular inherited condition, is Best disease. And best vitelliform macular dystrophy is an autosomal dominant condition. And that we tend to see, it tends to start in adolescence or adulthood. And the third condition that I'll mention is an X-linked condition, and that's X-linked retinoschisis. And that we see, that just affects boys or young men, not generally girls. So these are all very rare conditions, but because we're an eye hospital, we do actually see a lot of these conditions, but they are, in the general population, they are rare. And understanding the genetics of a condition when somebody comes with an inherited macular condition is going to be helpful for them for lots of reasons, just to understand their diagnosis, to understand the risk, and maybe treatment in some cases. So on this slide, I'll start with Stargardt disease. On this slide, there's what we call the pedigree, or that family tree that I mentioned that we draw when we're asking lots of questions. And here there's two people who are distantly related to each other, and they're not affected, and they have 3 children. And the first daughter, a circle, she's not affected. Then there's a daughter her circle is coloured in black, and that indicates that she's affected with Stargardt's. And then she has a younger brother who's also affected. Males, we do squares, females, we do circles. The affected female has children and they're not affected. Also, the unaffected female has children and they're not affected as well. So what I'm showing here is Stargardt's disease, which is a typical recessive condition. And with these recessive conditions, the carriers, the people who pass on the changes, the parents who each have a single change and they also have a normal copy of the gene, they're not affected. So with recessive conditions, someone who has just one change won't be affected. So that shows that a normal copy, one normal copy of recessively inherited genes is enough for normal function. So the children that are affected, they're affected because they've each inherited a change from both parents. And in turn, their children wouldn't be affected because they only pass on one of their 2 changes, and their partners would probably not carry a change. So with recessive conditions, what's important is we tend to see people affected just in one generation, and children of people who are affected with recessive conditions tend not to be affected. This pedigree, there's lots more black here. There's black squares and black circles, and they're in every generation. So this is a typical autosomal dominant condition like Best disease. And with autosomal dominant conditions, we have 2 copies of the gene, the Best 1 gene, and if one of the 2 copies has a change in it, then already that's enough to cause the condition. So that means that for every person who has Best disease in this family or has the change, there'd be a 1 in 2 chance that they would pass the change and the condition on to each child. And that 1 in 2 chances for every pregnancy. So that's why we see dominant conditions in multiple generations. And then the last type of inheritance is that I'm going to share is X-linked recessive inheritance. So I mentioned that we all have 23 pairs of chromosomes with all our genes on them. Our DNA is arranged in these long strands called chromosomes. 22 of those chromosomes are called the autosomes, and they're the same in males and females. The 23rd pair of chromosomes, we call them the sex chromosomes because they're different in males and females. And you might all know this, females are XX and males are XY. And there are genes that can cause macular diseases, inherited macular diseases on the X chromosome. So a female who has a spelling mistake on one such gene, let's say the gene that would cause X-linked retinoschisis, if she's got a spelling mistake in that gene, the RS1 gene, she actually has a second copy of that gene that's completely normal. So she is not going to be affected. Whereas if she passes that X onto her son, who gets his Y from dad, he doesn't have a second copy of that gene on the Y chromosome because he's only got 1 X. So he's got 1 X and this RS1 gene with a change on it, so he would be affected. So with X-linked conditions, we see like in this pedigree, there's only squares that are coloured. There's only males who are affected, and it's passed through these carrier females who are not affected. So when I mentioned that we do this, we ask all these questions and we try to get an idea of how the gene is inherited, to get an idea what the condition is. If we were to see a father pass a condition onto their son, we'd know straight away that it's not X-linked, because the father gives his Y to his son and he wouldn't give an X-linked condition. So that's one of the clues that we get when we ask all these questions and start drawing these family trees. So we've done the family tree, we've spoken to the family a bit about genetics, and then the next thing to do is to talk about testing. Do they want to do testing? And of course, it's completely up to them if they want to know what the cause is, because today we can do testing, and that's what I'm going to talk a bit about now. So first of all, why would anyone do genetic testing? Because at the moment, there aren't really many treatments for these conditions. There's an enormous amount of research, but there are not yet treatments. There are trials. For certain genes, there are treatments, but for a lot of the macular conditions, inherited macular conditions, there are not treatments. So why do testing? So one reason is because if we know what the gene is, out of the many genes that can cause a macular inherited condition, if we know what the gene is, then we actually know more about the prognosis. We know what to expect of it in the future. Is this a kind of gene that is going to cause a more stable condition, or is it one that is going to progress and get worse and worse? Is it a late onset condition? So we can learn a lot just by knowing what the gene is. The second reason that we might do testing is because once we know what the gene is, we actually know how it's inherited, because we know how all these genes mostly are inherited. So if we find out what the gene is and it's a recessive gene, then that already tells us that if this person has a condition caused by a recessive gene, like Stargardt's, then it would be very unlikely that they would pass it on to their children. There'd be a less than 1% chance, specifically with the Stargardt, with the ABCA4 gene. If it was a dominant gene, then we'd also know that there's a 1 in 2 chance that they could pass it on to their children. And the third reason that we do genetic testing is really just to have it on our database in the hospital, because there is so much research going on and there are trials going on, and it would be relevant, if there is a trial that's relevant for someone with a certain gene, we would let them know. So it's worth it because it will open doors to research studies in the future. Also, when there's a family where there's lots of people who are affected, once one person knows what their genetic diagnosis is, then that test could be offered to other people in the family, especially people who want to go on and have children. That's something we call cascade testing. So how does it go? How does it work out going about the genetic testing? So usually patients are referred through their GP or through another ophthalmologist, and they'd come to see us in the genetics clinic in Moorfields. They'd be examined, they'd see a doctor, they'd see the consultant, they'd have imaging, maybe electrodiagnostic testing. There'd be a lot of studies to try and see functionally what's going on so that we can recognize what's going on as well. And then really the icing on the cake is the genetic testing. And if someone in the family already has a genetic diagnosis, then the testing that we do is called predictive testing, or familial testing, because we know what we're looking for. Whereas if we don't know what we're looking for, then it's called diagnostic testing. And today, through the NHS, whole genome sequencing is offered to anyone with a suspect macular condition or a retinal condition. And whole genome sequencing is really the most comprehensive testing that is available, because whole genome sequencing would take a blood sample, would extract the DNA, and would sequence all of that DNA. And that's 3.2 billion DNA letters. That's over 20,000 genes that would be sequenced. And then that would be analysed to look for changes that are harmful and causing the macular condition. And most of the analysis would be focused on around 300 genes at the moment, but that number's growing all the time. And those are the genes that we know that can cause inherited retinal conditions. So it's very important when we consent someone for whole genome sequencing that we have a very detailed and important conversation with them, because when we test these genes, when we do genetic testing and we sequence the DNA and we read all those genes, it's quite different from doing a chest x-ray or a blood test to find levels of cholesterol or a mammogram, because we're not only finding out about what that person has in their genes, but because we inherit our genes from our parents, we're actually learning about other family members. So there are familial implications when we do genetic testing. Somebody could have a sister who has a son who's affected. So as soon as we do testing or our child does testing, there's other people in the family that there are conclusions that we can make because of that testing. So people do need to be aware that there are these family and wider implications when we do genetic testing. Another thing that we talk to people about is the different types of results that they could have. And we do need to manage expectations and let people know what the limitations are of the genetic test and what the benefits are. So one of the limitations is that often we don't find the cause, and it can take up to a year. So they all this effort, all this emotional effort as well, and they make the decision to do testing and they wait a year and a blank sheet will come back that we didn't find anything. And I'll talk about that a bit more in a moment, but the different results that we have are important, and sometimes they're actually unexpected results. They might find a cause, but sometimes that cause will tell us more than we wanted to know. It might be a gene that doesn't only cause the macular condition, but it might be a gene that's what we call a syndromic gene that actually causes the macular condition and something else, maybe hearing problems or renal problems or neurological problems. And for some people, that can be a nightmare because then they're always waiting for their child to develop these symptoms that they may not develop. But equally for other people, where the child does have a lot of different manifestations, it might actually be the end of an odyssey and it might explain everything. So there might be a sense of relief. So unexpected findings or incidental findings, they can be that we actually find a syndromic gene when we thought we were just going to find the cause of the eye problem. Another incidental finding is because they've looked across all the genome, sometimes they find things that have nothing to do with the eye condition, but they've seen it and it's important to tell the patient because they can do something about it. So we need to prepare patients for all these things, because if they didn't know that and then suddenly they have this, it can be quite upsetting, and they need to be sure they want to do this and know these different things that could come out of it. So if they do want to go ahead, we take that blood sample and then we feed the results back as soon as we get them. And as I mentioned before, sometimes we don't find a clear result. And that doesn't mean that the condition is not genetic. It could just mean we haven't yet found the cause, because we don't know all the genes yet that cause these conditions. And there is so much research being going on, and every year more genes get added to the ones that we're really looking at. So somebody might have whole genome sequencing, get a no primary findings, we haven't found anything, sorry. And then 2 years later, they'll get a phone call and they'll be told that actually through research, somebody looked at their data, which they would have consented to, and there's been a diagnostic discovery and they found the cause, and they might be asked if they're happy to be part of more research because it's a new gene. So it's an ongoing analysis as well, and things do get reanalyzed. One last thing that two more things that I'll mention, and then I'll be finished. The emotional side of genetic testing, and I think this applies to many conditions, not just genetic conditions, but you can certainly say that they come about with genetic conditions. And we very much try to support people emotionally and practically when they're going through this odyssey of learning what the genes are. But some of the emotions that family might have, guilt that they passed on the condition. We can't help it. There's that famous quote, it's supposed to be George Bernard Shaw, the brilliant playwright, and Isadora Duncan, the beautiful dancer in the early 20s. She turned her Bernard Shaw, and she said, wouldn't it be great if we had a child together? It'd have your brains and my beauty. And then he turned around to her and said, yes, but what if it had your brains and my beauty? So we can't help what we pass on, but sometimes we pass on something, it did come from us, we know it came from us, and so there's a sense of guilt, even though there's nothing we could do about it. And every single one of us carries genetic changes that could be harmful. So people naturally feel guilt. You know, it can get more complicated. There can be a family where there's 2 affected children and 1 unaffected child, and the unaffected child can feel guilty for being unaffected. Equally, anger. A child can be angry that their parents passed on, that both the parents passed on this condition, or an unaffected child can be angry that the whole family goes around the affected child. Patients might feel denial. They might know that there's a condition in the family. They might think they might have some symptoms, but they might be in great denial because they absolutely don't want to be like this grandparent who had, you know, for whom the macular condition got quite bad. And then, of course, as with all conditions, there's anxiety what the future holds. There's grief of what could have been, and a lot of frustrations with day-to-day life and careers, studies, relationships, all these things. So we do try and help people work through these emotions sometimes. Sadly, sometimes there isn't enough time to give all the right time that we'd want to. And for that reason, we sometimes refer on to clinical genetics or for extra psychological support. So sometimes with a syndromic condition, and also if patients want to discuss reproductive options because they know what the condition is and the only thing they can do about it, they might want to discuss, even if they decide not to, they might want to discuss in great detail their reproductive options of not passing it on to their children. Or if they have one child who has it, they don't want to pass it on to other children, or if someone's affected and they don't want to pass it on. So for these things, we often refer on to clinical genetics where there's going to be a lot more time. So for reproductive options, we refer on also for management of those syndromic conditions where they need to coordinate different systems that the child is affected with, would refer to clinical genetics. And again, we refer to counselling services where patients need a bit more psychological support. So to sum up, genetic counselling is about more than just testing. It's also about listening and explaining and supporting individuals and families as they navigate often very complex and very emotional information. And we always try to help them make autonomous decisions that lie within their value system and beliefs. So thank you very much for listening. I'd be very happy to answer any questions. And I will stop sharing now.
Thank you so much, Ellen. A really interesting topic and something we haven't covered before in one of these webinars. So really fascinating to hear something new, and obviously such a kind of complex area of healthcare and decisions for individuals. We've had some questions come in already, but if people have got questions they'd like to ask based on what you've said or how you answer the early questions, please do just type them into the chat and we'll try and go through them. So a few of the questions are about age-related macular degeneration, and the first question is that also inherited?
Right, so it's complex. There are certainly some genetic elements, but there are also some environmental elements like smoking and age. The genetic elements, it's not just one gene. So if you think about marbles in a jar, and if that jar is almost full of marbles, it's not overflowing, and those marbles are the genetic predisposition. So it's not overflowing, but there is quite a lot of genetic predisposition. So someone who has lower genetic predisposition, they'd have to have a lot of environmental factors to make the jar of marbles overflow and cause the age-related macular degeneration. But if someone had a lot of these genetic factors already, so the jar was almost completely full, for them, just a few more of the environmental factors would cause the jar to overflow and cause the age-related macular degeneration. So it definitely does have a hereditary element, but it's not the case of one gene that's causing it. Let's find that gene and then let's treat it and work out that gene. There are several genes. There are several big genes that have a big predisposition factor, but there are a lot of others that modify and change. So it's what we call complex or multifactorial. I hope I
Thank
answered
you.
that question.
Yeah, that's a really good answer. And this sort of builds on that, I think. Someone says they have age-related macular degeneration, and as does their sister. Though they aren't certain, their father may well have had it, although it was referred to as tunnel vision. What are the chances it could be passed on to their two sons and also their sons?
Right. So it depends on, it could be because they could all have a lot of these predisposing factors, and then they'd also have the, they'd need the environmental factors as well. Depends on how old they were when they had this. Sometimes people who come in with what looks like a much earlier form of age-related macular degeneration, sometimes it turns out to be not age-related macular degeneration, but one of these late onset inherited macular dystrophies, because some of them are quite mild and very late onset. So sometimes there's a confusion. Sometimes somebody will come in with an earlier onset and then they said their father or their parent had the age-related macular degeneration, but maybe that was just a very mild form of an inherited condition that they had, and they also had some age-related macular degeneration, but really there was something going on that wasn't picked up. So that is also possible. Doesn't mean that all the people with age-related macular degeneration have these genetic conditions, because that's not the case at all. And a lot of people get age-related macular degeneration because it is age-related and the system is slowly wearing down. And you add the environment, one of the biggest environmental factors is age. So, the
Yeah,
longer we're living, the more likely we are to get these conditions. And some people will have their genetics can be quite robust against the age-related macular degeneration. So they don't get it, and other people don't have those protective factors. So it can be quite complex.
as you say, very complex and very uncertain. I guess that in some ways they're helpfully some of the things you can do to reduce your risk, things like stopping smoking, eating a healthy diet, are good things anyway. There's
yes,
no,
yes,
they're going to
definitely,
help with all sorts of health conditions.
definitely.
How do you manage things when a parent has been adopted as a child and presents with a child of their own who has a genetic disease?
So that just means that we don't know about their ancestry, but that's okay. We don't have to know about the previous generations. It's just to give a clue. So we would test that parent who is adopted. When we test children, we like to do what we call trios, which is the child and both the parents. So if there's just, if that child has the two parents, sometimes it's just one parent. And if that child is adopted, we'd just test the child. We wouldn't do the trio, and that's fine as well. The trio helps with the analysis. It just means that if we were to find something, we might know that a parent of that adopted parent might have had something too, but we don't know about it. But we could, we'd still do the testing on the child and whichever parents are available.
Just working with the people
Yes,
you have and the information
exactly,
you have.
exactly,
Yeah,
exactly.
yeah. Thank you. Someone believes their mother had AMD from age 80, but one of her sisters also had AMD, so perhaps they had a genetic form, and they're asking, should they ask their GP if they can be tested?
So they're probably seen in a medical retina clinic or just regular follow-ups through their ophthalmologist or optician. And if it's, when someone gets something at the age of 80 and two siblings get it, they're both age related, so they're both quite older. So it could just be age related. So they don't need to start thinking that it's a hereditary condition. And the imaging is not going to be the same as well. So if they've had imaging at the, at the opticians, where they take pictures of the back of the retina, somebody could see, I'm not a clinician, but they would be able to see that this looks like age-related. And sometimes it's confusing and we're not sure. But with inherited conditions, they tend to be symmetrical in both the eyes. So that's always a clue as well. So when people are looking, they can see the signs of age-related usually, and they would, you know, if it looked like it could be genetic, then they would suggest that they were seen in a genetic condition, genetic clinic. You know, and sometimes we do get people who have very, very late onset. You know, there is a bit of a blur, you could say, you know, the genetic conditions that are so late onset, they're almost mimicking an age-related form, because if they only start at 80, so it's as if it was age-related. But it doesn't. Yeah.
And you've reminded me something else I should have mentioned, other than, as well as not smoking, eating a healthy diet, making sure you have those regular eye tests so that people can pick up any issues. And that's good advice for anyone at all, regardless of what your family history is.
Yes, definitely. Yes, yes, that's what we can do.
Thank you. How do you help patients decide whether genetic testing is right for them?
So it's so personal, and our job is really just to facilitate them to be able to make the decision. Nobody should feel pressurized. And nobody should feel pressurized to feel that if they have it, they shouldn't pass it on. So our job is very much to help them work out what's the best thing for them. There are ramifications of knowing, you know, if someone, well, just being tested, it might help to get to be, you know, somebody's vision impaired, then they get certain help as well. And a condition might just help formulate what that vision impairment is for them. Certainly, if someone is thinking about having children, they might want to know so that they can know if it's something that they might pass on, a dominant condition, or relax because it's a recessive condition and they're more unlikely to pass it on rather than worry about it. Certainly, knowing again for the future, hopefully there will be treatments, hopefully there will be trials for these genes. So you could say that once they've been tested and we've got it on our system, we're looking after that. And as soon as there's a trial or treatment for that gene, we would go through and make sure that the people who are eligible would have access. So it is a very personal decision, but sometimes people don't want to know, and that's fine as well. And I mentioned predictive testing before. Sometimes maybe, you know, a 50-year-old will find out that he has a genetic condition and it's dominant, and he has children in their 20s who are not affected, and he has a very mild version as well. And those children are at a 1 in 2 risk of having it, but they're not affected. So he might have told them, I have this condition. If you want, you can get tested. That's predictive testing. And that's very much up to them. They can choose, well, you know, I don't have any symptoms. I'm not going to live my life. You know, I don't want to know. But somebody else might say, well, I'd rather just know, and then I can deal with it. And knowing if I don't have it, then I can relax. And then if I do have it, then I need to think about, you know, just be more aware. So it really is a very, very personal decision. And in turn, if someone was under 18 or certainly under 16, we would never do predictive testing on children. So if a parent had something and they want to know if their child has it, or if one child has it, they want to know if another child is going to develop it, but that child does not have any symptoms, we would never test the child without any symptoms unless there was a clear treatment. Because that's going to influence how the child is interacted with on every level, and that can be hard for parents sometimes, and sometimes there are special cases where we would, but on the whole, for the autonomy of the child, we
So
don't.
they're gonna grow up and need to make their own decision, don't
Yes,
they?
exactly. So when they're 18, they can make that decision for themselves.
Yeah, it's so complex, isn't it?
Yeah.
The kind of different nuances of it. And how has the sort of technology in the field evolved since you've been working in this area? Is it?
It's really evolved. The whole genome sequencing has changed things a lot, because we used to work with gene panels where we just looked at the actual genes, and genes are actually made up of parts that become part of the actual message that tells the body how to make the protein or whatever it's making, and parts that are in between that get chopped out. So those intervening parts we never used to look at, because most of the changes that caused the conditions were in those functional parts. So we didn't look at those other parts. But now with whole genome sequencing, we can look at all the parts in between as well. And we are finding that there are changes in those parts that can cause these conditions that we were missing before. So there is very comprehensive testing now. There are limitations, and I mentioned that it can take a year to get the results back from whole genome sequencing, which is a long time. Privately, it takes much less. And the real limitations, there aren't enough clinical scientists, and because of equity, we are testing a lot of people, which is a fantastic thing, that we can test a lot of people, and people from different populations, so that all populations are represented. But especially the genomic laboratory hub, it's all localized, where we send our whole genome sequencing samples. They're quite overwhelmed with they have a lot to do. So everyone's working very hard, but it is taking a year. And that's something
Wow.
that AI is changing that as well all the time. So we're learning all the time, and there are new methods. There's ways of looking at big chunks, as opposed to just small chunks, and fitting them together. So things are evolving, methods are evolving, and it's all getting better and better. So
Well, that's good news, and I think you talked about some conditions for which there aren't treatments, and that obviously impacts on the approach to testing. And of course, what we hope as an organisation is there'll be more and more treatments available, which will hopefully
yes,
make the decisions easier.
yes,
I'd imagine if there's an available treatment, then the motivation for doing the testing, it's an easier
yeah,
decision, isn't it?
yes, absolutely, absolutely.
I'm just looking for see what other questions we've had come in. We've obviously talked about age-related quite a lot. Someone's asked what is age-related. In mid-60s, is this more likely to be hereditary, as they have macular degeneration in both eyes, and their father has it, and they haven't been advised that it could be genetic or offered any testing?
Right, again, it could be age-related. It could be definitely, and if they're seen by an ophthalmologist at any stage, they would be
Yeah.
they would have an idea. And certainly if they're concerned, then they can certainly get a GP referral. Often, just Specsavers or the optometrist will see something and will recognize that this could be genetic, and then they will say, maybe get seen, I'd like to refer you to Moorfields or somewhere. And then they'd be referred to us, but age-related can be from 60 for sure.
So she says there are other signs other than simply at what
Yes,
point develops the condition.
yes, yes.
Yeah, my colleague in the chat has just said, sort of building what you said, an OCT scan should be able
Right,
to
yes,
inform
exactly,
the
exactly.
optometrist.
So exactly. So these tests, they would be able to see and differentiate.
Yeah, so getting those regular eye tests, and if you have the option to have an OCT scan, which is now pretty widely available as well,
Yes, yes,
it gives so much more insight into what's going on in the eye. I'm just seeing we've had any more questions. We may be done in terms of questions in the chat. So I guess one sort of forward-looking question, just to wrap things up, where do you see the field of genetic counselling heading in the next 5 to 10 years? What do you think the future looks like?
That's a very good question. So more available to more people. It'll probably be more virtual. There'll be more time for people to have genetic counselling appointments, expanding the service, more available, and And hopefully in the future, with more results and hopefully with more treatments, we'll be counselling people on different levels as well.
Yeah.
So I think, you know, faster results and more availability to more people. I think,
Good.
and hopefully with the added treatments.
Yeah. It's a positive looking future then, so that's good to hear.
Yes, there are reproductive options available which have changed from previous years, so maybe that would also change, and that's also part of genetic counselling. You know, what options there are to not pass the change on that people are interested in, and that's something that's also changing. So that's something that, as genetic counsellors, we would also engage with the family.
Great. Well, thank you so much for your time. My colleague has posted a couple of links in the chat for those who are interested, just linking to some pages on our website with a bit more information on genetic counselling. And I've seen a few people in the chat are saying thank you and how interesting that was. So thank you again for your time. It's been lovely to meet with you and to hear about something that was completely new to me, and I'm sure to lots of people listening today. So enjoy the rest of your evening. And just to say before we finish up, so we normally have these every month, but we'll be taking a short break in September as we'll be having our macular disease conference, and we'll be back with our My Macular and Me webinars on Tuesday, the 21st of October, and we'll be sharing details closer to the time as to the topic for that. And just to remind everyone, our macular disease conference is taking place online on Saturday, the 13th of September, between 9:15 a.m. and 4 p.m. And we'll be joined by a huge range of experts in macular disease, including researchers and clinicians who will discuss the latest in treatments and research. And you'll also get a chance to ask them your questions in our live Q&A session as well. The event will also include practical advice on living with macular disease, and to watch online, all you'll need on the day is a computer, tablet or smartphone, and you can also join in using your telephone. And you can register online, and we will include a registration link in the chat, and I can see my colleague has already done that. So thank you everyone for joining today, and thank you again to Elena, and enjoy the rest of your evening. Take care everyone. Bye.
Thank you. Thanks very much. Thank you.